Going to talk about the management of proximal humerus fracture with the help of JESS fixator. As you can see, this is a bone model where I have mimicked a fracture. So this is a example of 4-part fracture where this is a lesser tuberosity, this is greater tuberosity, this is the head, and this is the neck part of the proximal humerus. Here, this is the location of the axillary nerve, and this is the spiral groove where the radial nerve is traversing and piercing the lateral intermuscular septum. These two neurological anatomical landmarks we need to take into the consideration while fixing the JESS fixator into the proximal humerus. It will be required for creation of a Y-frame of the JESS fixator for the proximal humerus. The most important component is the link joint, which comes in 2 by 2, 3 by 3 and 4 by 4 size. Here we will be using a 4 by 4 link joint for the creation of metaphyseal and diaphyseal holds. K wires, that is either 2.5 to 3 mm K wire or a 3.5 mm K wire, can also be used for the fixation into the humerus head and into the humerus shaft. In elderly patients where bone may be extremely osteoporotic, in such conditions threaded K wires can be used. This is the connecting smooth rod which will help in creation of the metaphyseal and the diaphyseal construct, and at the same time it will also give us connection in between the two holes. These are the link joint Allen keys of variable sizes. This is a drill and plier. These are the simple assembly which is required for the fixation of the proximal humerus JESS. Proximal humerus is all surrounded by muscles and it has a good vascularity. The wire passing safe zone is one wire can be passed into the lesser tuberosity, one wire can be passed into the greater tuberosity, and around 1 to 1.5 centimeters posterior to the greater tuberosity, another wire can be passed. In displaced fractures of the proximal humerus, 2 mm to 2.5 mm K wire can be used as a joystick to reduce the fracture and to control the rotation of the humerus head. So now we will be passing first wire into the greater tuberosity from the lateral side. Will be passed at the lesser tuberosity. And the third wire will be passed around 1 to 1.5 centimeter posterior to the greater tuberosity. Okay, like this. Now as you can see, we have passed 3 wires into the humerus head, one into the at the level of lesser tuberosity, another at the level of greater tuberosity, and the third wire, it is around 1 to 1.5 centimeter posterior to the greater tuberosity. As you can see, the angulation between wires may be variable from 60 to 90 degrees, and they are passed under C-arm control, and the wires will be passed up to the subchondral level of the humerus head. These 3 wires will help in forming a metaphyseal hold of the proximal humerus. Here, additional K wire can also be passed to gain the further hold or control of the proximal humerus. So with the help of plier from the smooth rod, we made this C-shaped half ring for the fixation of these K wires into the proximal humerus with the help of link joints. So now we will start fixing. This is a 3 by 3 link joint. It is opened with the help of Allen key. We need 3 link joints. So we will take 3. So with this hole, the link joint is passed. With another hole, the second link joint and the third link joint. After passing these link joints, fix them with the help of this arch. Sometimes due to the tightness of the grub screw, passing of the arch into the humerus head may become a little troublesome, but as one will progress to do number of cases, this will also be little easy thing. Sorry. You can bend this arch as per your convenience if it is getting difficult for passing into the link joint. So now as you can see, I have passed this into the link joints. Now I am tightening it, then Allen key, this is the edge tightening, and this is the final link joint tightening. Okay, so now this is the metaphyseal hold where you see 1, 2, 3 link joints connecting the C arch with the K wires, and this entire construct now can be used for getting the anatomical reduction of the humerus head, that is adding adduction to the humerus head. Thank you. In actual patient scenario, this gap, that is between the bone and the arch, should be little bigger because there is a bulk of the muscle, as well as there is also a hematoma which is which gives rise to a lot of swelling around the shoulder joint. So this distance, that is distance between the bone and the arch, should be little bigger. It should accommodate at least 2 fingers breadth so that the swelling can be negotiated. At the same time, this ends of the arch, that is the anterior end and the posterior end of the arch, should be cut so that they don't impinge the patient while sleeping or while doing activities of daily routine. And the cut ends, the wires at these ends should also be cut so that they are not too proud, so that the patient can easily wear the clothes. Now here we will be going ahead with the diaphyseal fixation, where the 2.5 to 3 mm K wires will be passed perpendicular to the long axis of the shaft and parallel to each other. The neurological structure which you need to take into consideration is axillary nerve, which is say around 5 to 7 centimeters below the tip of the acromion. So we are not going to interfere here in this neurological structure, but what might be bothersome is the location of the radial nerve, which is at the level of spiral groove, where it pierces the lateral intermuscular septum and proceeds down into the arm. At this point, if you want to extend your construct distally, you may have to explore the radial nerve here, see it under vision, and then pass the wire. So depending upon the extent of the fracture and the fracture geometry, we will pass 2 wires or 3 wires into the shaft of the humerus perpendicular. Stop. We have passed 2 wires into the diaphyses, which are perpendicular to the shaft of the humerus and dead lateral position, and we have spared the radial nerve which is passing in this direction. If you want to increase the hold of the fracture, you may go distally, but at this level you have to explore and dissect the radial nerve and then pass the wire in order to prevent the radial nerve injury. So now we will fix these shaft components with the help of link joints. This is the first set of link joints, and this is another set of link joints. So 4 link joints will be passed into these K wires. These are the smooth rods which are converted into a Y-shaped fashion with the help of plier. They will be connecting the diaphyseal hold to the metaphyseal hold of the humerus. So we will proceed further. First and second. Now we will pass the first Y rod into the shaft of the humerus. An additional link joint will be passed here into the proximal wire, and it will be connected like this. Once you get a reasonable positioning of the fracture, you can start tightening these link joints. Right. Now you can see this one rod is connected with the metaphyseal hold. As we connected initially with one curved rod, the diaphysis with the metaphysis, we added another curved rod which is connecting the diaphysis to the metaphysis, converting it into a Y-shaped frame. Therefore, it is called as Y frame of the JESS fixator. Here you need to use 2 sets of link joints over the K wires which are passed into the diaphysis. So this is one set and this is another set of the link joint, and they are connected with the help of grub screws to the metaphyseal hold of the proximal humerus. So in and all, you require 1, 2, 3, 4, 5, 6, 7, 8, 9 link joints, and you can use additional link joints and additional K wires for the fixation of the proximal humerus fracture depending upon the fracture geometry. So this is how a Y-frame of the JESS fixator for the management of proximal humerus fracture looks like. I am showing the frame.